We are live now.
Yeah, good morning, everyone. So welcome to this November 2025 edition of SMISS-AP Webinar series. This is a scientific endeavor of SMISS-AP supported by OrthoTV. So today's topic is extremely important. It is about MIS in spinal balance, and it is extremely relevant subject. So I strongly support this particular statement, very, very strongly. Every spine surgeon should be a deformity surgeon. In fact, I fed it to AI, this particular argument, and the reply I got that is a spine surgeon can create or correct a deformity. And this is so very true. Again, this is a very popular statement. Life is a kyphosing event. Of course it is, and this is because of lumbar disc degeneration and a function of osteoporosis, sarcopenia, etc. While it is natural, sometimes it can exaggerate and cause pathology. You can have pathological kyphosis. You can also have severe kyphosis as a result of conditions such as infections, previous trauma, idiopathic causes, etc., which will actually throw you off balance. And what does this have? What does this have? What kind of effect does this have on our body? So it puts a lot of stretch on the engines of our body, especially heart and lung. This leads to exaggerated energy expenditure, which can cause significant morbidity and lead to early mortality in these patients who are prone, which are basically adult patients. So the goal of non-conservative, non-surgical as well as surgical treatment in terms of spinal deformity correction is to get balance. Balance is basically a position of comfort, a position in which your head is on your shoulders, the shoulders are on your pelvis, and in this particular posture, you spend the least amount of energy. And this was popularized by John Dobusay, popularly known as the cone of economy. So the cone of economy is a core of comfort with regards to energy expenditure, and should be the goal of a spine surgeon with regards to his patient who is off balance. For time immemorial, we have been bombarded with this particular statement that lumbar kyphosis is bad. Of course, it is bad, but we didn't know how to quantify this till we realized that it is the pelvis which drives it. Again, this was popularized by John Dobusay, who stated that pelvic should be considered as the last vertebra. Of course, it is, because the pelvis is the one which dictates our global alignment. Pelvis is the one which defines spino-pelvic harmony. So this brought the spine surgeons to the drawing table, the drawing board, and got them back to mathematics to calculate these indices. I'm not going to go through these indices because this is a big topic in itself. Basically, it states that these particular parameters should be aligned to get to get a right sagittal balance. In fact, there are papers to suggest that if your parameters are aligned to these values, patient is in comfort, there is less pain, the quality of life is great. However, if it sways from these parameters, proportionally the patient is patient is disabled to that particular extent in terms of pain, disability, quality of life, etc. Again, the importance of these parameters lies in the fact that if these patients are operated and their alignment is brought back to these values, again there is reversal of the HRQL parameters such as SF12, SF36, ODI, etc. Basically, you get your balance right, your quality of health, quality of life improves. But it was not so poetic and not so straightforward. In spite of following these parameters right, surgeons still faced problems such as PJK, instrumentation failure, pseudarthrosis, etc. So that is when there were feeding of so many other classifications and values. Almost every year there is a new parameter added to this big armamentarium of measurements. So, such as the modified Russell classification, which shows that there are different types of lumbar alignments. Then there is a gap score, which predicts, mechanical failure following a ASD surgery. Again, we forget that, there are age-related spinopelvic thresholds, which we need to respect. A 60-year-old will not have the same parameter as someone who's 75-year-old. So that needs to be taken into consideration. Again, there are several other factors such as osteoporosis, sarcopenia, which can influence treatment of patients. Again, as I said, every year there is a new parameter added. There is another parameter which I went through very recently, which is called the posterior cranial vertical line, which has a great degree of agreement with sagittal alignment. I wish to know what my next speakers follow, which formula do they follow when they plan their surgeries. That would be very interesting to know. Keeping the parameters aside, keeping the assessment of alignment aside, now when it comes to actual manifestation, actual correction, what are the principles we follow? So kyphosis can be corrected only by two ways. Either you lengthen the anterior column by releasing ALL, fixing hyperlordotic cages, doing artificial disc replacements with adequate lordosis, or you shorten the posterior column. So there is a range of osteotomies that one can do, in a graded manner, from as small as Pontius osteotomy to as big as vertebral column resection, depending upon the dimension and magnitude of the deformity. There are plenty of opportunities when it comes to open surgery. Again, as I said, from Pontius osteotomy all the way till a vertebral column resection. So these opportunities help in revising a case, re-revising a case, revising a case. That is the opportunity that you get in open surgery. But when it comes to MIS, our hands are tied a bit. While tubular decompression, tubular discectomy, endoscopic decompression, or endoscopic discectomy, etc., may help in treating postural deformities, which are a result of pain. Structural deformities can be corrected with only anterior column lengthening. Of course, there are a few case reports here and there where they've done osteotomies, but the main driver is anterior column lengthening. And how much of correction can one expect when you lengthen the anterior column? So with the ALIF procedure, which is usually done at L5S1, you can get up to 12 to 20 degrees of lordosis. With OLIF, maybe about 8 to 12 degrees. And with TILIF, again, now there is an increasing interest in using expandable cages, which can raise your lordosis to up to 12 degrees. We are devised our own technique of flipping the cage. This we have seen gives a lordosis of another extra 10 degrees if this particular procedure is executed. This particular technique is executed. Basically, turn and flip the cage once it is in situ. Again, when it comes to deformities, especially long deformities, the ASDs, there are quite a few challenges MIS has. Extending ASDs, application of multi-rods, which is a part and parcel of open surgery nowadays to decrease the incidence of pseudarthrosis, doing multiple level osteotomies. And again, radiation plays a big role in MIS because these surgeries are image guided. So these are burning issues with MIS. For those who are new into this deformity correction paradigm using MIS, this is an excellent classification, which if I see the way I deal with my cases in retrospect, this is something which I follow. Class 1 is those cases which we need, just decompression. Class 2 is maybe MIS TILIFs. Class 3 is, additional procedures. Class 4 is wherein, you need to depend on open surgery. So one should be a good open surgeon first before you are attempting MIS. So these are cases of endoscopic discectomy, where the decompression, where there is improvement in uh, postural deformity. These are of course transient deformities. Again, this is another patient with lumbar degenerative scoliosis, but he had only left-sided leg pain as a result of L5S1 lateral recess stenosis. All this patient needed was a tubular decompression at that particular level. Deformity correction doesn't mean you need to always put screws and rods and correct it. Postural scoliosis, postural kyphosis can something be corrected with just decompression and discectomies, just as shown here. There's another patient who had a degenerative scoliosis, but the patient had a sharp shooting pain along the L3 dermatome alone, and though it showed a good amount of degenerative scoli, rounded scoli, correcting the apical level, which was focused at that particular root, was good enough to correct her deformity and give a lasting relief in this particular patient. Again, high-grade spondy, which can throw you off balance, can be corrected using minimally invasive techniques. This was another patient who had a very high BMI, high cardiac risk, high pulmonary risk. He had liver issues. He had undergone a previous L3 to S1 fusion. I had done the surgery. Now he developed ASD at L3-4 and L2-3. He was a big challenge to treat now because of his extreme comorbid conditions and obesity. So this is somewhere wherein we applied our principles of MIS, because opening this guy would have been a hell. So since the L5S1 was fused, we left the pelvic screws alone and we extended our surgery with T-lifts at these two upper levels. Again, there are umpteen examples of correcting bad deformities using MIS, using anterior techniques, mini open techniques, using posterior osteotomies, with added advantage, added dependence on robotics, navigation, etc. I think just sky is just a limit. So to conclude, spinal balance lies at the heart and soul of spine surgery. It has implications on pain, comfort, and quality of life. While open techniques are well established, MIS techniques are evolving and path-breaking. I would invite today's speakers to share their experience and knowledge. As a first guest, I would like to invite our very accomplished Dr. Niraj Vasavada. He's a leading spine surgeon in Ahmedabad. He's at Zydus Hospital. Recently, he was invited as a keynote speaker at the European Spine Society Congress. And we are very proud of him. And his talk was on spinal balance in MIS. I request Niraj to share his slides and go ahead with his presentation. Thank you, Niraj.
Thank you, Dr. Arvind. Well, it was probably a flattering introduction. As they say that, in Newton's word, we stand tall on the shoulders of giants like you. So I guess, we have followed your path to reach where we are today. I guess, my talk is this European spine talk, which you wanted me to give. It was very focused on MIS and lordosis correction in segmental as well as multiple level degenerative spine deformities. So I'll just, strictly confine my talk to this topic only. Well, I guess, I'm taking over entire sagittal spine profile and, various adult deformity principle is probably an entire day symposia. So I'll just, quickly go through my talk on restoring sagittal alignment in degenerative lumbar spine and lordosis control. So I have nothing to disclose. I am consultant to one of the Indian manufacturing company for some of the cages. As we know that, and Arvind has described it very critically, that balance is a critical for normal function. Gradually, science has started recognizing this pelvis is the vertebra, which broadly determines how the balance should be. So it is the three-dimensional position of the pelvis, which actually and eventually decides how your spine should curve for normal functioning. The left side of the figure is probably one of the most well-known figure by none other than Jind Bose, and he described cone of economy, wherein the central cone is where absolute normal function comes. Then the secondary cone is where it's a balanced spine, where there is balance is maintained by a lot of compensatory mechanism, and the final circle wherein the spinal imbalance sets in and there is no longer capacity to compensate for the balance. So we have to aim to keep our spine either in the lowermost circle or the thinnest circle, or at least in a compensatory position to function normally, beyond which that function just goes away. Now, when we look at the concept of balance, balance is not one thing, it's a composite of segmental lordosis. Segmental lordosis, which gives a regional distribution of lordosis, and eventually it gives the global integration of sagittal profile. So segmental errors during surgery, it cascades upward. Under correction in lower segment forces compensatory hyperlordosis proximally, increasing the stress and accelerating degeneration. So until and unless you restore your segmental profile properly, you cannot restore a global alignment. On the nutshell, the other way to look at this slide is that core concept of sagittal balance is achieving lumbar lordosis. If you can achieve lumbar lordosis properly, probably you can achieve a good sagittal profile in your patient. So what were the alignment goal? Dr. Schwab came up in around 2005 and 2006 with a comprehensive study by ISSG, and they came up with a spinopelvic harmony principles, wherein if your lumbar lordosis minus pelvic incidence, so PI minus LL, which is less than or equal to 10 degree, that is they considered as an optimal sagittal profile. So everybody started focusing on this mathematical notion that your lumbar lordosis should be within 10 degrees of plus or minus 10 degrees of pelvic incidence, and we all know that pelvic incidence is a fixated mathematical parameter, and entire surgical plethora surgical procedure started focusing around this core concept. Further studies, further knowledge, as it expanded, ESSG came up with a very interesting observation that despite we try to achieve this absolute PI minus LL of around 10 degrees with pelvic tilt less than 20 degree and SVL less than 5 centimeter, in this subset of patient where we have strictly adhered to this mathematical alignment, 52.60% patient had implant related or mechanical complications. And this study was published in 2017. Then the ISSG again came up with a revised criteria, and the age appropriateness was considered very important. That spine has a kyphotic process. As aging progresses, spine goes in a kyphosis, and in an elderly population, it is okay to accept some amount of kyphosis or some amount of less than optimal sagittal imbalance rather than achieving absolute numbers. While if you are doing the same surgery in younger population, you need to strive hard to achieve these sagittal parameters. So they came up with a formula that if your age is less than 35 years, you need to adhere to this formula as strictly as possible. But if you are going beyond 70, you can accept some amount of sagittal imbalance. It was even in a less than 50 years, somewhere you are flexibility was introduced in this core alignment. So concept of age appropriateness gradually started taking into play, and this led to a very extensive study and by Dr. Yelgor, and they came up with a gap score where this age appropriateness was taken into account. But they also noticed that age appropriateness was also not sufficient, but you have to take into account the pelvic type as well. You have to restore your lordosis so that the lordosis distribution becomes more important in lumbar spine while restoring your sagittal alignment. And accordingly they came up with a 4 type of pelvis. Type 1, type 2 are low PI, then type 3 is average PI, and type 4 is a very high PI patient. And the concept of lordosis distribution index came into play, wherein you have to strive really hard to achieve 2/3 of your lumbar lordosis at the lower lumbar level, that is L4 and L45 and L5S1. So in a high PI patient, you have to restore majority of lumbar lordosis at lower PI, and also keep into account the upper lumbar lordosis, which is in a lordotic segment. But in a low PI patient, the upper lumbar lordosis will become more or less straighter. So you have to keep into account the apex of lordosis which is there and the inflection point into kyphosis. If you don't restore this pelvic harmony or lordotic distribution, somewhere you are striving for a failure. So clinical takeaway from this entire slide was alignment goals are not just static numbers. They must evolve with patient's age, PI, and pelvic morphology. In MIS deformity or a fusion surgery, we have to aim for proportionate, not perfect correction. Adequate lordosis distribution without overcorrection is the key to restore sagittal parameters. So where does MIS fit in into this? Now, MIS adoption has its own paradox. Minimal invasive spine surgery was popular for reduced tissue trauma, blood loss, and very fast recovery. However, generally it is believed even today that it has a key limitation in often restoring insufficient lordosis. So all this technique came into play. It started with MIS TLIF, then went into transpsoas, then went into anti-psoas, and ALIF is still a workhorse for majority of lower lumbar lordosis restoration. And now we have started doing even a transforaminal transcambin fusion in spine. So where all this technique fits into while dealing with lumbar lordosis. So when MIS is appropriate, Arvind has just given this particular diagram. You have to consider this whenever there is no significant PI minus LL mismatch or no significant sagittal malalignment, you can go for MIS surgery. But whenever there is a fixed deformity or a deformity which is not amenable to just anterior releases, you have to strive to go conventional open surgeries. So more or less, class 1, class 2 deformity. Class 1 is almost normal. Class 2 is minimal sagittal malalignment. And some of the class 3, wherein you will have to do anterior column realignment by anterior releases, you can do MIS surgery. But class 4 is a big no even today for MIS surgeries. So next question comes is, which technique should we adopt to achieve this lumbar lordosis? Now, MIS TLIF in a country like India, where we don't have a lot of surgeons who are performing ALIF surgeries because of various cost reasons, exposure reasons, or MIS TLIF is still a workhorse for MIS deformity correction. The major challenge in MIS TLIF is, can we achieve appropriate lordosis? If you look at global literature or a global key opinion leaders' opinions, MIS TLIF is looked down today as far as a lordosis or segmental lordosis concerned is required. Say, for example, this particular patient with significant high PI, grade 3 listhesis, segmental kyphosis, can we achieve MIS lordosis in this kind of a patient? So the main core of achieving surgical lordosis in MIS TLIF is you have to plan appropriately. How much lordosis is required? If we can achieve by MIS TLIF, whether your spine is mobile or stiff, if your spine is mobile, achieving lordosis becomes quite easy. But if your spine is rigid, as it is in this particular case, achieving lordosis may be a challenge. What are the surgical challenges we need to keep into account? Like osteoporosis is an enemy of surgeons, and any attempt at MIS sometimes may lead to a hazardous outcome, and you have to plan for that in properly. When you are doing MIS in a high PI or a lordotic achieving surgeries, position of the patient also becomes very important. You see this particular case wherein you can see that your spine is almost at a vertical level. So positioning this patient will be a challenge, and you will be operating at a very awkward angles under microscope. So make sure that you are compensating for this hyperlordosis by tilting your table in a reverse Trundleberg position, and then you perform your surgery. To achieve lordosis, you have to force your pelvis into extension so that the lordosis is quite restored when you try to do a release from MIS TLIF techniques. And there are certain surgical tips by which you can achieve lordosis even in MIS TLIF. You have to plan when you want to do a unilateral or a bilateral facetectomy. If your spine is mobile segment, then unilateral facetectomy is good enough. But in a rigid or kyphotic, bilateral facetectomy, either by docking two tubes on both the facets or from ipsilateral side, doing a facetectomy on the other side would be the mainstay of treatment. Say, for example, in this patient, you can see that this patient is a fused segment, and just doing a unilateral facetectomy will be a great challenge to restore a sagittal lordosis. Distraction and compression is also very important. So you have to leave a room so that you can achieve a good compression. You have to try to locate your cage as anterior as possible so that you can compress posteriorly, and try to put as large or a long cage possible in your patient. As Arvind rightly mentioned, expandable cage has opened a new era in management of lordosis in MIS
TLIF. This is just a video how we can achieve lordosis after release. You can see that, this patient is positioned optimally. We are trying to release disc, complete release of disc is achieved. Then we do a good discal release. Now here the most important point of release would be to release both the lateral aspect of annulus, either again by docking two tubes on the facets or by doing an over the top decompression and releasing opposite side of lateral annulus, and that gives a very good lordosis. You can even do a opposite side facetectomy from ipsilateral side, as it is shown in this video. You can see that my osteotomy is removing facet on the opposite side, and you can actually do an SAP excision and even the opposite side lateral annulus release, so that your segment becomes entirely loose and you can put that in any amount of lordosis you want. You can see that, properly performed MIST lift, even in a kyphotic spine, can give a 20 degree of lordosis very easily. Now, the next question comes is when to use OLIF or ATP approaches, because OLIF and ATP approaches are championing the concept of ACR, wherein you can achieve a very good release anteriorly. Now, in India, we don't perform transpsoas technique so often because of fear of femoral nerve palsy, and somehow majority of our surgeons are trained with anterior procedures via anterior to psoas procedures only. Here also cage positioning will become most important after doing a proper release. If you want to achieve lordosis, you really need to put your cage as anterior as possible. Make sure that you are not damaging anterior longitudinal ligament. If you do, you will have to supplement it with anterior fixation. But if your goal here is indirect decompression, you will have to position your cage slightly posterior, so that your posterior disc height also get restored, and then you can achieve compression to achieve your lordosis. You can see that by doing anterior surgery, a nice amount of lordosis can be restored this patient. Alpha S1, there is still no debate that ALIF scores the way, and ALIF is the way to go to restore the majority of lordosis in your patient. ALIF is purported to restore around 25 to 30, even sometimes 30 degree of lordosis in one of our patients. We tend to do it, via a lateral position ALIF approach in our patients. We are quite used to doing this kind of a procedure, and we are quite happy. Sometimes you encounter this kind of a patient wherein there is significantly rigid deformity, and you will have to think about using a hybrid approach, wherein we did our OLIF surgery or the anterior release, and despite that, there was significant amount of deformity which was remaining because of the posterior constraint. So we did a posterior mini open Wilson's approach kind of a technique, and we did bilateral facetectomy or a mini ponte kind of an osteotomy, and we could do in a single segment. So if we compare and summarize this entire technique, it has a capacity to restore on an average around 15 degrees of segmental lordosis. However, approach surgeon and complication we need to keep in mind. OLIF is probably mainstay in our part of the world and can restore around 10 to 12 degrees of lordosis, and majority of surgeons are getting used to this technique. MIS TLIF still is a workhorse in our country, and if properly performed, it can give really adequate lordosis, much more than what literature is predicting. You need to focus on proper bilateral release and bilateral facetectomy in some of the cases to achieve a good lordosis. Overall, the interbody can restore per segment around 6 to 8 degrees of lordosis. So you need to keep this in account when you are planning to do a sagittal balance decompression. Now the new technique, a new baby in the town, which is full percutaneous transcambin oblique interbody fusion, where this lies. So the concept of this fusion technique is it's full percutaneous, fluoroscopic guidance, very minimal resource required, excellent coronal correction, extremely minimal blood loss, and outcomes are comparable with MIST leaf as far as our data, unpublished data so far is saying. The limitation, it has significant limitations, that lordosis restoration is quite limited. It has a very steep learning curve, and contraindications are osteoporosis, severe stenosis, and immobile joint. You can do this procedure if your segment is in a satisfactory lordotic position only. You cannot attempt this procedure to restore or realign your spine into a lordosis. So ideal suitability would be single or double level with preserved segmental lordosis. Ideal for Rizzoli type 1 and type 2 pelvis. Try to avoid in Rizzoli type 3 or type 4 pelvis unless the segmental lordosis is nicely restored preoperatively only. Preferred in isolated coronal plane correction. It is generally used as an adjunct to O-leaf, A-leaf, and T-leaf in MIS deformity correction, specifically at the upper lumbar level, where no significant lordosis restoration is required in majority of our cases. However, if you have a good mobile spine where restoration of lordosis is adequate in extension, the patients with high BMI, where any surgery you would want to do, as for example, this patient is a 42 BMI patient, and any kind of surgery you want to do this in patient would be a challenge because of the fat cover around, wherein this kind of percutaneous procedure is really works wonder, specifically when your segmental lordosis is restorable in extension. And you can see that from 7-degree pre-op to 24-degree post-op restoration was possible via this technique. Most ideal in adult deformity is combination of technique and circumferential MIS. Say, for example, this is our own 10 years back operated case of MIS T-lift comes back to us with significant adjacent level, multi-level deformity and adult deformity. Now, here the challenge was we did not wanted to open the previously operated segment. So what we did was we did L4534 olive with anterior connecting rod at the 4-5, and then rest of the things we did from posterior, and the transcambine was done at the upper lumbar level. An entire construct was connected with one single construct. Now, this is another patient where there is significant coronal as well as sagittal imbalance is present. Now, in my books, either you will have to do A-leaf at L5S1, or you will have to really do an open surgery. So we decided to do this in a hybrid way, wherein L5S1 was done with open T-leaf, wherein we did bilateral facetectomy. We put a large cage in front. We used pelvic screws, and rest of the things upper level were done in a MIS fashion, something like this. You can see this. This is a transcambine incision, wherein we did L1 and L2 as a transcambine fusion. Then first we did in a lateral 2-level olive. Then patient was flipped prone, and this A-leaf kind of a large cage was inserted with pelvic fixation, and from posterior only these two cages were inserted, and you can see the nice sagittal profile has been restored in our patient. Now, which technique particularly you want to use at which level? Ideally, there is no dispute that alpha S1, as far as possible, try to use A-leaf, but if not A-leaf, do proper posterior release, and you can get away by doing a nicely performed MIS T-leaf or an open T-leaf with large cages. L4-5, if you don't want to restore lordosis, you can go away with MIS T-leaf, but if you want to do a lordosis L4-5 and higher lumbar level, try to do anterior. At L1, 2, 3, sometimes interior surgeries are a challenge where you can use the transcambine approach. So multi-level, you try to do anterior. If it is 1 or 2 level, MIS T-leaf is good enough. Alpha S1, as far as possible, you need to do a A-leaf surgery. However, surgeon comfort and familiarity and training decides the way forward. To summarize, pelvis dictate the blueprint. Combined swab and LDI gives better outcome. The lordosis distribution index and segmental lordosis distribution proves critical in most of our patients. MIS achieves robust correction in appropriately selected patients with strategic planning. Each approach has its specific indications and application, and you need to keep that in mind. A failure of MIS primarily is the failure to plan. Never try to treat every surgery with one technique. You should have all the technique in your armamentarium to achieve a proper segmental lordosis. Thank you so much. Arvind, you are mute.
Anyone has questions for Niraj? Niraj, you have evolved from T-leaf to O-leaf to K-leaf. So, what is? I mean, I went through your presentation, but what is your strategy? So, what technique are you inclined towards nowadays?
So, alpha S1, I have started doing more and more A-leaf, or you can say a large kidney cage.
in MIS TLIF. So L4-5-IS1, I tend to avoid doing KLIF now. I think KLIF for me, it is an adjunct to, as I said, OLIF, ALIF, or MIS TLIF when I'm dealing with adult deformity. Or I will do KLIF only when there is, lytic listhesis, pre-restored lordosis. Otherwise, multi-level, I would want to go anterior. If it is 1 or 2 level, I think, I would not bother to turn the patient. I'm yet not used to doing a prone transpsoas. I think, Dr. Raymond can probably throw more light on that, because in Australia, they are doing quite frequently the transpsoas prone lateral approach. I don't have an experience with that, but if it is multi-level deformities, and I tend to go for 3, 4, 4, 5, 5 as one interior, and about 2 would be a K-lift. If I cannot do A-lift for whatever reasons, then posterior L5S1 would be either bilateral MIS T-lift or a mini open kind of a T-lift, where I can do a good liberal release and put a large cage with posterior compression to achieve a good lordosis.
Raymond, any questions?
No, it's all been very clear.
Okay.
So yeah, the anterior techniques are definitely more powerful to achieve lordosis correction.
Correct.
And I agree that in our elderly population, we don't need to correct so much lordosis, because that is actually a very high risk factor for PJK and PJF if we try and overcorrect them.
Yeah, so we are on time. I can see some young blood here. So Dr. Guna is an accomplished young budding surgeon. He is from Madurai. He has a lot of credentials to his correct, which is beyond the scope of today's dimensions of time. So I'd like to call him and give his thought on how he would use his MIS armamentarium in correcting spinal deformities.
Yes, sir. Is my screen visible, sir?
Yes, yes.
Yeah. Good morning, everyone. At the onset, I would wish to thank the SMISS-AP organizing committee for giving me this opportunity to present.
Guna, just a minute, sorry. Audience, if you have any questions, please post them on the chat box so that we can relay your questions to the speakers. Thank you. Yeah, sorry, Guna, please go ahead.
Yes, sir. Thank you, sir. So I'm Dr. Guna from Madurai. Thank you for allowing me to present in this prestigious webinar series, sir. So I'm here to talk on staged MIS approaches in managing adult spinal deformities. Beautiful introduction, basic clarification on managing these deformities has been given by very experienced, accomplished MIS surgeons like Arvind sir and Niraj sir. So I have no conflicts of interest to disclose. I would like to sincerely thank Dr. Jacob with whom I worked for the past few years for giving me the case examples which I have put in this PowerPoint presentation. I was proud of all these cases which I have quoted here. So as we all know, adult spinal deformity is increasingly recognized as one of the prevalent conditions worldwide.
Guna, there is some echo, it's not very...
Okay.
I think you've got these feedback loop from a speaker or something. There's some echo. Okay. Your voice we're hearing your voice twice, so it's overlapping, so it's difficult to understand.
So maybe he's logged into.
It's better now. It's better now.
Yeah, it's
better now, sir.
Yeah, better now.
So just a minute. So I'll continue, sir. Yeah. So the primary reason being increased life expectancy and enabling technologies that made the management of these complex conditions. So management is usually individualized based on the patient's comorbidities, and also they have very clinical presentation like some patients.
No, again it is back to the same.
Just a minute, sir. Just a minute. Give me a second.
Maybe you can remove your earbuds and just use laptop mic and everything.
Yeah, it's like you have two microphones going. Maybe your earbuds and your computer.
So better now, sir? Is it better now?
Yes.
Yes, sir. So
So conservative treatment is usually the first line of management in these patients, and the refractory patients benefit from pain management strategies like.
We can't see your slide.
Sir,
we can't see your slides. Yeah. Okay. Now yes.
Yes, sir. Now you can see, sir.
Yes,
Yeah,
I can
see. We can see.
I can see. I can see.
Yeah.
So worsening back pain, patients with radicular pain or neurological deficit or altered spinal balance would benefit from surgical intervention. And surgical correction usually involves achieving a well-balanced spine, achieving a proper neural decompression, and overall a solid fusion, thereby relieving the patient's pain. Over the years, as already discussed, the posterior approach has been the main workhorse for patients, and it is more suited for mild and flexible deformities, as sir has previously mentioned, whereas moderate severe deformities mentioned from a hybrid or a combined approach where there is a good anterior release and a posterior fixation. And the complications and ASD surgery always go hand in hand, as it has been already well established in the literature. These patients are more prone to medical, surgical, mechanical, and neurological complications. Medical complications like DVT, cardiopulmonary issues, whereas surgical complications like deep-sided infections, delayed wound healing, wound dehiscence, mechanical complications ranging from screw pullouts, pseudoarthrosis, and PJKs, and worsening neurological deficits causing disabilities to the patient. And there is a strong literature evidence stating that as the invasiveness of the approach increases, the complication rates keep climbing. And we can see the complication rates of about 35 to almost 50 degrees, 50% in certain studies, with revision rates going up to 30%. So less is definitely more in this subset of patient population. And then comes the minimally invasive surgery, which is recently climbing up in the era of spine surgery. As we and there are multiple papers suggesting that MIS approach has definitely a big role in ASD patients. And studies have quoted a combined approach like lateral surgery with a posterior approach significantly improves the coronal alignment, lowers the incidence of pseudoarthrosis, and provides better quality of life in these patients. And lateral approach, mainly the pre-psoas, has recently gained attention as it is a true minimally invasive approach with extraperitoneal access and more of a muscle splitting approach rather than a muscle cutting approach with the minimal blood loss and better coronal plane correction in these patients. So, what is a staged approach which I am about to talk today? It is basically a two short surgeries instead of one long surgery, especially in this medically fragile population, where we combine the MIS laterals with the MIS posterior. So what does it does? How does it make a difference? It reduces the surgical burden by minimizing the overall prolonged time of the surgery and anesthesia time. It also enables us to provide a surgical pause and reassess the pelvic parameters after stage 1. The posterior construct length can also be assessed after the correction initially through the lateral approach. And usually the laterals achieve decompression through an indirect decompression, and the necessity for a direct decompression can hence be assessed after the stage 1 surgery. And the most important being it provides a circumferential MIS approach which can be adapted in a surgical armamentarium. So this is a pictorial representation which I have shown. So stage 1, which we usually do, is a lateral approach, and L5S1 we can prefer a ALIF approach. Laterals OLIF at multiple levels through a single incision, and stage 2 usually placing percutaneous screws, pedicle screws, and providing a tunneling the rod under the fascia to achieve the final correction. If at all we need a decompression in stage 2, it will be a Ponti's osteotomy through docking the tubes and removing the facets and providing a lateral recess decompression. So how do you preoperative evaluate? Are all patients suitable for this circumferential MIS approach? So the main thing which we need to evaluate is the preoperative planning. And the routine things which we do is a whole spine standing radiographs and the lateral and the supine radiographs. This gives a assessment of this flexibility of the spine, as in the supine the spine becomes less flexible, avoiding the gravitational forces. We assess the overall balance, assess the segmental and regional deformities like thoracolumbar kyphosis, loss of lumbar lordosis, pelvic retroversion, etc. We also take into account the coronal cobs of these patients. So in the CT scan, as the main aim of this surgical strategy is indirect decompression using a lateral approach. A fused facet is definitely a contraindication, and you have to go for a direct decompression. So we check for the fused facets in CTs, look for a lateral bridging osteophytes. That gives an idea of how much release has to be performed, the extent of the release. And we also look for the end plate morphology, as a strong osseous bony end plate is a prerequisite for achieving a good indirect decompression in these patients. And finally, the magnetic resonance imaging, we look for the levels of the canal stenosis. And if there is any sequestered disc as shown in this second image, it definitely needs a direct decompression posteriorly through a laminotomy. And we also look for the L5S1 disc status, whether the disc is well hydrated, look for it, Firman grading of the discs. And finally, for the accessibility of the lateral approach, we definitely look into the vascular and soft tissue anatomy, like aberrant vascular structures in the corridor or a high rating psoas. So usually after a stage 1 lateral approach, we provide an interval of 2 to 5 days depending on the patient's physiological condition, the recovery of the patient, ask the patient to start weight bearing and mobilize on the same or the first post-operative day. Look how the radicular symptoms have disappeared or the persistence of the radicular symptoms. Then radiologically, we again do a supine and standing whole spine radiograph to reassess the pelvic parameters again so that it can be optimized during the second stage. So this is the stage 1 which we routinely follow, standard OLIF approach by placing the patient in the left lateral decubitus position. And as you can see, it is a muscle splitting approach, no muscles are cut, no bleeding. Even we can place up to 3 kgs as we have shown in this image, and the blood loss is very minimal, less than 100 ml. And stage 2, we usually plan after, as I said, 2 to 5 days, then place the position in the posterior approach. We usually, for a 3-level approach, we prefer using a standard midline skin incision and providing subfacial stab incision to improve the cosmetology of the surgical approach. And if at all we need a decompression, we dock the tubes and perform a Pontes or a lateral recess release in the same sitting. So coming to few case examples, this is a patient, 68-year-old female with a significant coronal and sagittal imbalance. You can see the head is off both in the anterior and posterior. It is not over the pelvis. As you can see, the coronal curve is 38-degree multi-level lumbar degenerated disc with listhesis at 2 levels. And there is a significant PALL mismatch with the retroverted pelvis. So this patient needs definite correction of the sagittal imbalance. So this is after stage 1 where we performed 3-level OLIFs, L3 to L5. You can see the pelvic parameters improved, lumbar lordosis improved to 39-degree with the good correction of the coronal cobs. We did a significant release of the lateral osteophytes and both the annulus, ipsilateral and the contralateral side to achieve a good coronal correction. Stage 2, we did a posterior instrumentation and percutaneous, as I have shown before, and we were able to achieve a good correction of the sagittal and coronal profile where the head was sitting over the pelvis. And the lumbar pelvic incidence minus lumbar lordosis mismatch is reasonably and proportionate to this age with good correction of the overall sagittal alignment. This is another case where the patient had a significant sagittal imbalance rather than a coronal imbalance with good coronal translations of the in the both sagittal and coronal planes and good pelvic incidence lumbar lordosis mismatch. As you can see, the corridors of OLIF is reasonably good at L2-3. So we went for a L2 to L4 OLIFs, and then we placed percutaneous fixation as shown in this image. And finally, we were able to achieve a good lordosis. In this case, we performed a L4-5 MIST lift as there was not a good vascular corridor anteriorly. So we had to choose a L4-5 MIST lift. Finally, achieve a very good correction in both coronal and sagittal planes. This is the follow-up CT scan showing very good fusion at all the levels at 1 year follow-up. This is the last case, which I'm going to show as an example. This case has a significant thoracolumbar kyphoscoliosis with a good coronal imbalance with C7 CSVL difference of 9.7 centimeter and a good PILL mismatch. However, the patient had normal neurology, no significant canal stenosis at the MRI. And as you can see, this patient had a poor corridor for OLIF at L2-3. However, we were able to do L3-4 and L4-5 OLIFs in this case. This is a CT scan of the patient showing multi-level vacuum sign, lateral bridging osteophytes, and significantly collapsed disc height. As you can see, this patient has a lumbosacral transitional vertebra at L5S1. So this is after the 2-level OLIF, we were able to reduce the coronal imbalance to almost half of the pre-operative standards. As there was a poor corridor for L2-3 OLIF, we were not able to do a OLIF in this case. So on this case, we have to do an open surgery. As compared to the previous cases, the head was still off the pelvis. There was a significant coronal shift of the trunk in the standing X-rays. So we had to open this case and we had to place a 4-rod construct considering the stress in the lower implants and the coronal shift in this case. So what I would like to suggest is circumferential MIS approach cannot be applied are not suitable for all the cases. We have to take the cases individualized and plan accordingly according to the patient. So as you can see, the coronal and sagittal profile and pelvic parameters improved in all such cases by our strategy. We also use a larger footprint lordotic cages up to 12 degrees in OLIFs and satisfactory fusion rates with improved clinical parameters in our patients. So this two-stage surgery in adult spinal deformity is not new, and it has been going through a lot of literature recent times. The last 5 to 10 years, Professor Neil Anand and his group have been working a lot in this circumferential MIS strategies, and there are a lot of publications in this regard, and which he calls them as the simpler technique, which is mainly based on ligamentotaxis, where we distract the anterior column, restore the height of the anterior column, thereby releasing the ligaments, and this provides a very good strategy for correction of the deformity without needing to perform any osteotomies like a pelvic subtraction osteotomy or a bilateral facetectomies in the posterior part. So there are several limitations, as I have previously said. It's not suitable for severe fixed deformities where we have to release the osteophytes and you have to go for an open approach. And unfavorable surgical anatomy, as I have shown in few case examples where the vascular corridor or the soft tissue corridor is not conducive for a lateral release. And it also involves a steep learning curve. It's as experience gathers, you have to choose your complex cases. And technology also plays a very important role where adaptation of navigation, robotics helps the surgeon and reduces the surgeon's fatigue. And it also aids not only in the surgical part, it also helps in the planning part. Your robotic softwares are well equipped with planning softwares where you can plan your screws preoperatively. So technology has definitely a role in this circumferential MIS approach, and definitely a cost concern in a country like India where cost is a major factor. When you are planning to stage the patient, you have to keep the patient in the hospital for almost 10 days, which can escalate the cost of the patients, and financial constraint is a big part as a limitation for this approach. So the take-home message is, in appropriately selected patients, a staged MIS approach with better planning helps in better correction of the sagittal coronal parameters, and segmental and regional alignment is better restored. And after stage 1, you can reassess your pelvic parameters and customize the posterior instrumentation accordingly, where you can reduce the posterior armamentarium. And this we have published recently in few of our journals. AO Spine, we have published it as a invited guest blog also. So I thank for the opportunity which the webinar and the committee has given me to present in this prestigious, among the prestigious giants in the field. Thank you so much.
Thank you, Guna.
Thank you, Professor Raymond. Thank you.
Hi, any questions for Guna?
I just have a question. Do you worry about PJK? Because I noticed you stopped it around the thoracolumbar junction. So would you be worried about PJK developing, or because a lot of people would just span the TL junction just to mitigate the risk of PJK?
Yeah, that's a very good question, Professor Raymond. Actually, in all our patients, we look into the Ruzzoli's type of the patient. We also look into the gap score, whether the patient is severely disproportionate, mild, moderately disproportionate. There are a few criteria which we look before spanning into the thoracolumbar junction, which include the gap score, whether the disproportionate of the patient, the Ruzzoli types, and the quality of the discs at T12L1. If the disc is well hydrated and the patient is mildly disproportionate with a good disc height and well hydrated disc, we have a tendency to stop at L1. But most of the cases, when there is a significant deformity and we need to go to lower thoracic, we end up at T10.
Now, for both Niraj and Guna, so when you do your O-lifts and K-lifts, this is for the knowledge of the audience, where do you get your bone graft from?
Can I answer, sir?
Yeah, please go ahead. I'll answer later.
Yeah. We can use demineralized bone matrix, and there are some calcium sulfate crystals available also. And then we mix that with the bone marrow aspirate, where we aspirate blood using Jamshedi needle from the iliac crest and mix it with both, and then place it inside the cage, sir, from our experience.
So same we do, because we in India again, cost is a major issue. So we use the DBM mixed with TCP, tricalcium phosphate granules, and we mix it with bone marrow aspirate. And I think in my experience, we have studied our patient who has completed now 1 year. Hopefully, I've submitted the data to one of the journal. I don't know how and when it will get published, but we have been successful in K-Leaf in demonstrating around 89% to 90% fusion rate, grade 1, grade 2 Bridewell. So I guess, this approach gives satisfactory fusion rate. In addition to that, Arvind, if I may, I have basically two comments. One, as Dr. Raymond rightly said, that I think there is always a concern about stopping at L1. In my experience, also we have stopped at L1 in some of the patients or many of the patient, and I guess the jury is still out about when what should be our UIV. Very recently at Nash, there was a beautiful paper. They studied, they had done a systematic review of this UIVs, and surprisingly they conclude that upper our lower thoracic or upper lumbar has no significant difference between PJKs and PJF. That's the recent meta-analysis they published. I was also quite surprised with that, but that is, the literature is changing. Second comment I want to make about as Guna said, that upper lumbar level, one of his last case where 2-3 was not amenable for the OLIF. These are the cases where probably this transcambine has a very significant role to play. That you just can put the cage percutaneously without opening much, and all level cages would give a better sagittal profile. And one more comment is, it's not about, I believe, I think I would want to have an opinion of the house. You, Dr. Arvind and Dr. Raymond, you both are more experienced than what I am. But I feel, it's not about the cage profile or lordosis of the cage. Unless and until you do a proper release, whatever cage profile you are using, it's not going to help you in restoring your sagittal alignment.
Yeah, so there are other several factors, the compression across the rod that you achieve, that also adds to the lordosis that you get. The alignment of the patient, when you align the patient for surgery, there itself we can manipulate so much to get your lordosis right. And this paper is published also in Spine, the way to stop your upper instrumentation. And there was a previous paper also in JBJS long back where they did not find any difference between T10, T11 and L1. This was by Lenke.
Yeah.
So
in fact, some of the papers which I have gone through, one with JBJS and the spine, they have said that PJK and PJF rate is lesser if you stop at L1. But as Guna said that, I mean, these are subset of patients. You cannot, apply that principle in all adult deformity patients.
But the thing is, what happens is those lower curves, actually, when you go up, when you have to stop them, they end at T11 or T10. So that is the reason sometimes you need to go all the way up.
Yes.
Yeah, and one more limitations of all this paper published so far, what I believe, what I've gone through is, these are the papers, they are taking data from, very earlier kind of patients, where this LDI was not much given, stressed upon. The Rizzoli types were not included into it. The inflection point, lordosis distribution, all those things were not started taking. I think, the gap score and Rizzoli thing, they started coming into foray only after 2016-17. So I guess, we are still waiting data, what's the rate of PJK, PJF with this kind of, parameters after we take into account into our planning.
Yes.
So Niraj, there is a question from the audience. So the question is, how do you protect your exiting route during K-Leaf?
Yeah, so I guess, one is, you have to do adequate opening of the disc space percutaneously, and we always use intraoperative neuromonitoring. So we have now threshold of 6 MA as our threshold. We try to stimulate transcambine zone with 6 milliampere of current on IONM. And if it gives a safety, then, we go ahead, and we haven't found any problem so far. Second is, not to put too large cages. In our series of 43 patients, where we have studied, some of the patients, they started having third or fourth day ganglion irritation signs like, burning, acute neuritis, and they all subsided with steroid, but the majority of them were, we have tried to put cages 12, 13 or 14, so you have to refrain yourself from putting this large size of cages when you are doing transcambine fusion. See, you have to understand the idea of indirect decompression is to provide stability and, achieve foraminal height. If you can achieve that optimally, you don't need to go on putting large and large cages in your patients.
Now, the second thing is, so few cases I saw where you're in these long deformities, you stopped at L5. I've seen, even literature says about 40% of these patients to end up having problems at L5S1. So what is your experience? Why not, include them? Because, extending to L5S1 later on can be a little bit of a problem in these patients. They're going to age, they're going to put on weight, etc. So is it worthwhile considering fusing if L5S1 at the same time when you do the primary surgery? And what, in case you are against, what are the criteria we use when to fuse L5S1, when not to?
Arvind, it's a question to me or Guna?
Both.
Okay, so let me take that question first, if it's okay, Guna.
Yes, sir.
So
Yes, sir. Yes, sir.
yeah, I mean, I think I'm not fan of stopping at L5 in majority of my cases. As far as if I find that L5S1 as is preserved in lordosis and disc is not significantly degenerated and facets are not very severely arthritic, I tend to go just away without doing L5S1. The notion that I mean in future L5S1 might require the surgery. uh, Actually, in adult deformity, I believe that we never know that when the second surgery would be required. So I would want to just get away by doing as less as possible. Majority of literature also says that when you extend your fusion to pelvis, that increases the chances of PJKs and PJF and upper lumbar level deformity. So I think I mean if I can preserve alpha S1, no, that helps me. Third is clinical aspect. In my experience, I have seen that leaving alpha S1 behind, that probably in Indian subset of patient who wants to bend, who want to sit on the ground, all these things you can probably allow them if you have not fixed your alpha S1. That is what my experience says. So yes, if disc is proper, facets are not severely arthritic, and preserved segmental lordosis, I would want to leave away alpha S1 if it is not into deformity.
Yes, sir. I completely agree with you, sir. Completely agree with you. Also, if the patient, as sir said, if with the well-hydrated disc, no facetal arthrosis, no joint effusion, and clinically patient does not also have a L5S1 radiculopathy, I'll definitely spare L5S1. But most of our cases, when we are going for long constructs, we'll definitely try to involve pelvis into it to provide a strong base at the base of the construct, sir.
Yeah, so that.
I would agree. If the L5S1 disc is normal, we would tend to leave it. Then, I mean, I have been putting TDRs in now for degenerated L5S1 as an adjacent segment with a more proximal fusion, and they've been working quite well. There's a greater risk of the TDR failing because of the increased stresses on the TDR plate from the fusion above, but it's still an option. So you've left the option open. And I agree, if you fuse the L5S1, you've got one less motion segment, and it does increase the risk of probable risk of PJK above because it just means more stress at the other end. So you're basically fusing another segment, and you just got just the top moving now. But previously, you have some mobility left, especially if they're sitting on the ground.
Guna, one more question. So when you do this stage surgery, suppose it's a hypothetical question. So patient you operated, you've done the first stage, and patient complains of leg pain. So what is your algorithm now that the patient has pain?
So if the patient has leg pain, mostly it is due to the most stenotic segment, most probably. So I will plan for a direct decompression using tubes. Probably it will mostly be one or two segments, sir. Mostly at L3, 4, L4, 5, lower segments only probably will be the culprit. Then I will plan for, while positioning my screws, I will plan for a tubular decompression. I will dock my tubes and decompress at the side of the symptoms, sir.
So some surgeons, they do a MRI, right? Post.
Okay.
I'm just asking.
Yeah, some surgeons do, sir, but I don't routinely do an MRI in my settings, sir.
I think I would also agree that just making your patient walk and just feel the preoperative pain should be enough. Arvind, if I can ask a question to Guna, Dr. Raymond, what's your experience about this prone trans psoas? I'm always worried that when you are doing multi-level trans psoas, sometimes it may lead to psoas pain in your patient. Prone lateral trans psoas looks very promising, because you don't have to change position. You can get all the advantages of anterior procedures. Uh, I have no experience. What's your experience? Both of the esteemed faculty.
Can I answer, sir? So I personally haven't done any prone transpsoas, but I have assisted and been part of several cases, sir. The main problem with transpsoas is in laterals you have the luxury of pushing the psoas posteriorly with ease, whereas in prone laterals it's quite difficult to push the psoas because of the gravity. The psoas always tend to fall in the front, and it also at higher levels like L23, L34, you need a triggered EMG to look for the lumbar plexus throughout your surgery so that you don't injure the plexus. So those are several concerns, but as you rightly pointed out, it helps achieve a good lordosis because of the positioning of the patient, sir. But personally, I don't have any training and this experience with transpsoas, sir.
Yeah, I've never done a prone transpsoas. I've done a lateral single position, but I didn't like that. I just put the cages in laterally and then I proned the
Yeah,
patient and put the screws. I
yeah,
tried a few and I didn't like it because I
yeah,
think the
because
patient it's so hard to put that lower pedicle screw in properly because you're hitting the bed and I'm just not used to it. So
yeah.
I just take a tea break,
Yeah,
reposition,
so
and
so
put the
so
screws
because
in
I guess
posteriorly.
a lot of North American surgeons are fan of doing this prone lateral transpsoas. So
Yeah.
I'm also equally concerned about one concern is you keep on mutilating psoas level by level. What would be the outcome of the patient? I have no clue about it.
Yeah, and I think the lumbar plexus, because the psoas drops anterior, it may actually end up, more in the way, the lumbar plexus. So I'm not sure about there probably isn't a difference if you know what you're doing, but there might be an increased risk of plexopathy.
Sir,
But those who are doing it, they are continuing to do it, especially in Australia. Even I have heard people do have a series of 200, 300 cases. So there must be some secret, some tricks, tips and tricks to the technique.
Yeah. I would want to learn those tips and tricks on them.
Sir,
And
I would like to have a question to the experts in the forum, sir. Just as most of the patients with ASD have osteoporosis and sarcopenia, for osteoporosis, we'll start anabolics. And is there a specific protocol or specific supplements you follow or rehabilitation strategies for tackling sarcopenia in such patients? I would like to learn from the experts.
Okay, so for all of the patients who have any sort of instrumentation, we always would have a bone density check. And the one thing with many, many spine patients, and I think spine patients in more than other patients, is that they're all vitamin D deficient. I've not actually seen one which is it's rare to find a patient with normal vitamin D levels, especially in Southeast Asian countries, because we're darker skinned in general, and people tend to stay out of the sun, and they're all D deficient, and D deficiency is a risk for both sarcopenia and osteopenia and disc degeneration. So all of these factors make outcomes of surgery worse. So we correct the vitamin D level, we correct the bone mineral density, and we have strong drugs such as Evenity, romosozumab. So we routinely use that drug now preoperatively for any patient requiring instrumentation surgery where they have a suboptimal T-score. And even if during the surgery they're fine, they still get a few doses afterwards. If they're having a spinal fusion, it will help speed up, promote the spinal fusion. If not, it'll possibly help prevent subsidence, but subsidence usually happens early on after surgery. So my main concern is actually subsidence and loosening of construct because of suboptimal bone quality. And then you have to take them back in and do more. It's a nightmare. So it's far better to prevent it than have it occur. And we sometimes advise, so it's vitamin D supplements, calcium supplements, bone anabolic agents in preparation for surgery. So some patients will get 6 months before they can have a surgery to allow these drugs to work. And if they're weak, we'll get them to try and do some sort of physiotherapy or core strengthening program before.
Okay.
If they can, but they're usually in pain. So that's usually, sometimes it's difficult for them.
I think, in Indian setup, another challenge is our patients' lifestyle, which leads to this kind of problems, rather than their aging. Majority of Indian population are, they are on very low quality of protein. So, I think, I don't have a strategy to improve their sarcopenia. And unless, they are really, really eager to, do proper exercises. I think, only thing what we can do in our setup is just try to lower the expectation of outcome in this kind of patient. Because as Dr. Raymond rightly said, it not only increases subsidence, even PJK, PJF rates are much more in sarcopenia, leaving apart even the osteoporosis. So, and that dietary restrictions, religious dietary restrictions, what we have, patients are very reluctant for taking high quality proteins. They are not very keen on. They might not have exercised for years together. So to put them on an exercises or having a proper rehab protocol, it's great challenge. However hard you explain them, they don't follow. So somewhere you have to lower their expectation, out
Yeah.
of the clinical outcomes.
Thank you, sir.
Yeah, so with me, basically the same basics, strength training and high protein diet.
Yes, sir. Thank you, sir.
So,
Okay, so
can I invite Raymond to go ahead with his presentation?
yeah, so I'll share my screen.
So it's totally different take on MIS and spinal alignment. He's one champion of motion preservation surgery.
Yeah, so can everyone see my screen?
Yes.
Yes, sir.
Okay, so I have been doing far fewer fusions now. Probably probably 90% of my surgeries are TDR now. I do very few fusions. The approach is exactly the same as an ALIF or an ACDF, but instead of putting in a fixed device, we're using a device that can tilt and replicate the function of the original disc. So that's the main difference. So these are my disclosures. I am a consultant for Spineway, which is the implant I'm using. So I'm helping them design the implant. Balance. So the concept of balance, I want to argue that balance is not static. So when we talk about balance, we're usually talking about how we balance when we stand up straight. And this is human gait. So this is why it's so important, because if we can't walk, it's severely disabling. So we compensate for that. And when we fuse our patients, we always put them in the standing posture. But we sit down, and this is what happens to a lumbar lordosis. It basically disappears. 2/3 of the motion is in the hip joint and 1/3 is in the spine. So when we sit, our lumbar lordosis disappears. And when we have a spinal fusion, the spinal fusion is fighting this posture. This is an X-ray of someone sitting and standing. You can appreciate what happens. The femur and the spine is at 90 degrees, but the spine has actually also gone through 30 degrees. So the hip, you could say the hip back angle is 90 degrees, but some of the motion's actually in the spine above the pelvis, and 2/3 of it is below the pelvis, but there's 1/3 of the motion is actually occurring in the spine. So if we fuse the spine, we cause problems. So the balance, we're balancing the spine in the standing posture, but we're not balancing the spine when we're sitting. With the TDR, we can actually replicate this. So you can appreciate from this patient that they have a very good lordosis when they're standing, and when they're sitting on the next X-ray, that lordosis has disappeared. So TDR can be an MI surgery. This is a single level TDR, it's a 5 cm wound, and this is a 2-level TDR, which I did about 6 months ago. That was about 5-6 centimeters. So we can actually do it more or less distance between the discs. As we know, lumbar lordosis is not static. So even if we're sitting, we can have a lumbar lordosis range from 10 degrees when you sit at a Japanese restaurant on the floor, or if you're sitting with your back straight upright, it can go up to 50 degrees. So lumbar lordosis is not static. So if you have a spinal fusion, doing this type of slouching on the sofa versus sitting up straight becomes very difficult, especially the slouching position. So we sit more than we stand. So this is a study from European Heart Journal over 6 countries, and they looked at 15,000 individuals, and they looked at their daily activities. So we sleep for roughly 7 hours a day. We're standing for 3 hours a day, and physical activities 2 hours, 2.5 hours a day, and we're actually sitting for 10 hours a day. So when you're home at dinner, when you're watching TV, when you're in the office, when you're in clinic seeing patients, you're sitting. So sitting actually takes up more time than standing. So if we have a spinal fusion, the times that we sit down, we're actually compromising the proximal and distal levels of that spinal fusion, because that's where the motion is now occurring. So the risk of PJK and PJF increases. So this is just a diagram showing how long we're sitting for, and sitting actually takes up most of our activities. So if we fuse, we're not accommodating this posture, which is very important, the sitting posture. So overcorrection of lordosis is a risk factor for PJK, and PJF is a more severe version of PJK. And this is an example of someone, not my patient, but what happened is they had a 2-level spinal fusion, the adjacent level broke down, added 2 more screws, went home, developed PJF, so a fracture of the L2 vertebra, fracture of the UIV, had additional instrumentation, went home, tried to move, pulled out the screw, and then had the spine fused from the upper thoracic down to the lumbar spine, but left the L5S1, so probably will get an L5S1 problem later. So we know that from the cervical TDR experience, so many of us do cervical TDR because we know that the cervical spine is mobile, and if you fuse it, it's a major disability, that we can get excellent restoration of range of motion. So, and this is an example of a cervical TDR, and you can see actually where the motion is occurring. It's occurring at the TDR. So the TDR is moving, and above the TDR, there isn't that much movement because the TDR is doing most of the work. And when we analyze the MRI, so I've got preoperative and postoperative MRI, so lots for my patients. We've done the TDR at 5, 6, and 6, 7. And if you look at 3, 4, and 4, 5, 1 year later, they're actually better. And the reason is because there's less pressure on the 3, 4, and 4, 5 because we're restoring motion to 5, 6, and 6, 7. So it's taking the pressure off. So we're seeing reversal in disc bulges at the adjacent levels, not making it worse as you see with an ACDF, but making it better. And this same effect occurs in lumbar spine. So this is a lumbar spine patient with totally collapsed discs. They're not moving much, so you might argue that fusing it wouldn't actually deteriorate her much more because she's not actually moving much between flexion and extension. She's got foraminal stenosis. But after the TDR, she has gained 10 times the motion in the instrumented levels from 1.5 to 15 degrees. And when we looked at her MRI 1 year later, look what happened to the adjacent disc. They actually improved. So with TDR surgery, we can actually do less surgery. We don't have to instrument every single level. We just instrument the affected levels, and we don't worry about adjacent segment disease because the TDR is a protective device because it's reducing stress. So when we apply TDR to deformity surgery, often we only have to treat the actual pathological segments and not worry about anything else because we're actually restoring normal spinal dynamics now. So this is a patient with 2 prior microdiscectomies. He came into my clinic and saying that he doesn't have back pain, but he just can't walk properly. So I analyzed his gait, and his pelvis is retroverted. His lumbar spine, I can't make out where his waist is because I don't know where his lumbar spine is, because just looking at him, you can't see where the buttock ends and where the waist begins. So he's got lumbar kyphosis. He's got thoracic lordosis, and his cervical spine is straight because the thoracic spine has gone backwards. So it's made the T1 angle very horizontal. So now his cervical spine is straight as well. So loss of cervical lordosis. So this is the impact of a lumbar deformity on the thoracic and the cervical spine, and also, as we'll see later, on the hip joint. So he's got severe sagittal imbalance. So just measuring the PILL, he's got roughly 20. He's probably 20 degrees out. He's a Rusli 1, increased tendency to lumbar DDD anyway, and I can draw a straight line through his entire spine. So from the cervical spine down, it's going through all of the vertebra, going straight down to the sacrum. So he's got no spinal curves to speak of.
Okay.
This is the measurement. So you see the PILL mismatch here. He's got a thoracic kyphosis of 3 degrees only. A lower thoracic spine is in lordosis. This is the MRI. So we're not looking at any neural compression here. We only have 2 damaged discs, collapsed discs with some modic end plate changes. So you could argue this is discogenic back pain, but he doesn't have any back pain. So he's just got a postural issue. So what do I do with him? So some 3-4 disc has mild degeneration, some mild foraminal disc herniation, but he's not complaining of any ridiculous symptoms. The previous microdiscectomy a bit too overzealous and ended up with a small pars fracture at L4. So this might not be a contraindication. So I did a 2-level TDR for him, and that's what it looks like. And we got him up 5 days after surgery for an X-ray, and this is what the X-ray showed. So everything came back to normal. So lumbar lordosis restored, thoracic kyphosis restored, cervical lordosis restored. His hip also, his gait also normalized. And now I realize what happened is because his pelvis is now able to antivert and his hip joint is now able to clear the pelvis. So there's no more posterior hip impingement. So that fixed his abnormal gait as well. And long-term follow-up, we followed up with CT, and even the pars defect healed. So the TDR actually stabilized him sufficiently enough so that the pars defect actually healed. So this is a close-up of the pars. It actually healed the pars defect that was previously there. I was totally surprised by this. So I would argue that this is just a short presentation, just to explore the possibilities of TDR, that TDR is fully capable of doing anything that an A-lift can do, except it can accommodate a more flexible spine. So that would be the end of my presentation. So I prefer to do TDRs over fusions, and this is the reason. So we can achieve everything that we can do with a fusion, but we can preserve the motion, which is the main difference, which can accommodate the sitting posture, which most of us do. And we don't realize that if we have a spinal fusion, I actually advise my spinal fusion patients to be very careful with movement, because if they move a lot, they're going to end up breaking down the adjacent level. So no sit-ups. Try to avoid loading the spine axially, because all that pressure will go onto the remaining cushions in the spine. So we'll end the screen share. Okay, thank you.
A great presentation, Raymond. Food for thought. So, Raymond, I have a few questions. One is, so if it is a young patient and you're doing L5-S1, what could be your counseling regarding retrograde ejaculation?
So retrograde ejaculation occurs because of injury to the hypogastric plexus. So I'm very, very careful when I'm dissecting around that area. So we'd normally try and take off the prevertebral fascia which has the hypogastric plexus lying on top of it, and just push it off the spine. And because the hypogastric plexus is supposedly more on the left than the right, a right side approach, in some studies have said that it's safer to do a right side approach at L5-S1 to address this possible issue. But in a young male, I will warn them that, under the age of 30, if they haven't had a family, or if they're over the age of 30 and they still want to have kids, that there is a potential risk for retrograde ejaculation, especially if they've had previous surgery there. So if they've had or they've had one patient who developed retrograde ejaculation had some surgery for varicocele, so when he was a baby, and there was some scarring. So those would be risk factors. But I know that many people, possibly from Middle Eastern countries, would be very worried about this, and they don't want an anterior approach for this reason, because their reproductive rate is very high. So that would be a major problem for them, because large Muslim families would be, because that would be a major problem for them, because they usually have many children. So not being able to be a father would be a problem.
And second is, what are your strategies for revision?
So for L5-S1, you can go in on the other side. That's not an issue. And I've also gone in on the other side at the other levels as well. So the adhesions are usually around the peritoneum. Once you get to the spine, it's not too bad. So you can approach from the other side. If you go on the same side, I have done some where the patient has had previous A-lift surgery, and it's been so many years that the scarring's actually matured, and it's not that adherent. You can still find the surgical plane. If there is scarring, I'll usually dissect onto the, rather than enter the peritoneum, I'll usually go on top of the scar. So I'd sacrifice some of the muscle layer, probably leave some, so retract some of the transversus muscle layer to get retroperitoneal, to get to the, once you're into the retroperitoneal fat pad around the colon, it's usually not that scarred. It's usually around the front.
What is your revision strategy in terms of failure of the device?
So the device that I'm using has been tested to 40 million cycles. So that was a clinical paper that I did. So it went to 40 million cycles with no evidence of fatigue. Just, I think it was 0.7 mm loss in height of the device. It's a viscoelastic device, so there is no wear on it. So the only moving part is the viscoelastic core, but there's very little movement between the viscoelastic and the end plate. So there is very, very little mechanical wear on the device. So they've tested it to 40 million cycles. So what I tell my patients is they're about 40 years old or 50 years old. They come in and I say, you've probably got, you've got 1 million a year to play with. So 1 million divided by 365 days is you touching your toes 2,700 times a day. So probably most of us don't touch our toes 200 times a day. That would translate as roughly, for the hours that you are awake, touching your toes 3 times each minute for the rest of your life, non-stop. So the device, I tell them, should outlive you. This is the device I'm using, but there are devices that I know that would fail within 6 months. So the problem with lumbar TDR is there's many, many devices. Some are good, some are horrible, some are a complete disaster because the body is very destructive. The forces inside the body. So that's why you can end up with rod breakage. So device failure is not uncommon. So we have to advise, which device to use. But so the main problem I was finding that was with the devices that we were getting, and some of them, I've tried some devices, I stopped using them within 6 months because we were seeing problems. And then the other problem with TDR surgery, a lot of people would say, I can't image, or I'm worried about MRI. But this one you can image very well because it's titanium. So there's very, very little imaging artifact. So what I say to patients, to people who've had or surgeons that want to explore TDR surgery is if you know how to do an A-lift, if you know how to do an O-lift, it's not actually that difficult to change to doing a TDR because it's very, very similar. The only difference is that we have to fully mobilize the segment to basically break down any possible restraints. The PLL, when I go back in, it actually reforms. So we've seen the PLL grow back. And there's usually a lot of dense tissue around the front. So it's not ALL, but it's scar tissue. So once the implant has been in there for a few months, the scar tissue around it acts like a natural barrier and restores the capsule and the ligament stability.
Raymond, I have a question. It's a wonderful eye-opening talk for me. One concern which I always have, in my mind is alpha F1 still, I think, I can understand it's whether you do an A-lift or you do a TDR, probably approach, everything will remain same. Specifically, when you go at upper lumbar levels, I always ask myself and to all the experienced surgeons like you, is it worth taking so much of risk at vascular mobilization, vascular injury, specifically 3-4, 2-3 if you're planning to go? What's your take on that? That's really scary for me.
Okay, so the riskiest level vascular wise is L4-5 because you have iliolumbar veins running across. So if you can't locate them or if you can't mobilize the vessel. So if you pull one out, it bleeds like crazy. Just a small vein will bleed a lot. It's always going to be a venous injury. I've never had an arterial injury. So because the veins are very thin and they're usually stuck, the artery is not usually stuck to the spine, but the vein can be stuck to the spine because it's more posterior than the artery. So it's mobilizing the vein. 3-4 is usually not an issue. 2-3 is usually not an issue. 1-2 is an issue. So I've never done a 1-2 TDR because 1-2 you have the level. It's at the level of the renal vessels. So I've spoken to surgeons who have done a 1-2, but usually that disc is so high up it doesn't degenerate. And even if it degenerates and you fuse it, if you've got a mobile segment below, you've seen from the slides, the upper lumbar isn't as mobile as the lower lumbar. And the reason why it's always lower lumbar is because those discs are moving the most. So we only usually see upper lumbar issues after we've done a fusion below. They don't usually degenerate normally. So by restoring motion below, I don't need to do anything above. So I often leave mildly degenerated discs. So that's the beauty. We actually can do less levels. So 1-2 is just the issue concerning the renal vessels. The artery and vein are usually not stuck on the disc. So it's just the risk of segmental vessel bleeding up there. And you can usually see that. It's very easy to identify the segmentals. They're constant. They're just usually just below the end plate and just around there. So you can always identify those. So it's just the risk of that bleeding. So it's mainly 4-5, which would be the hardest level to do.
So how do you safeguard that level? Any tips for that?
It's mobilization of the vessel. So usually, I've done quite a few, so I can mobilize everything now. But if I find that the vessel is actually stuck onto the disc, I'll mobilize it with the periosteum, and just take a layer of the disc off, the anterior annulus of the disc, and it will mobilize. So I just had one last week. We just strip off the periosteum and take it off with the vessel. But it's being able to mobilize it always involves the iliolumbar if it gets in the way. So taking down the iliolumbar vessels.
So you don't use your approach surgeon now. You are doing it.
No, I do these myself. I've done lumbar TDR 20 years now. But in the past it was using devices that could possibly fail. So mechanical discs, so with wear and tear, much like a hip and knee replacement. So those could potentially wear out. And we couldn't get MRI with that. So, and it was hypermobile, so it'd be restricted to one level. But the newer device is actually viscoelastic, so it's got recoil. And if you handle it, you'll see that it actually doesn't move much. So patients are actually quite surprised when I show them this thing actually moves because it's actually very strong. So you can barely compress it with your fingers. So it feels like it actually looks more like a cage, but it has the elastic properties of a natural disc.
Dr. Raymond, it was a very good presentation. Actually, I just have a few questions. What is the learning curve for anterior LDR, lumbar disc replacement? You have been doing it routinely, but for young surgeons who are willing to take up for a disc replacement, the main problem and challenge is the access, where we need a vascular access surgeon. So what do you think the learning curve is? Is it very steep learning curve, or?
I think if you're already doing OLIF and then you go to OLIF 5.1, it's almost there. And we are actually developing a TDR that can go in from lateral now. So if you can do an XLIF or an OLIF or DLIF, you could probably put one in.
Okay.
But the current device is now put in direct midline anterior, or it has some offset teeth where you could probably put it in at roughly 20 degrees oblique, so a bit like an OLIF, but I still do it under direct midline anterior.
Okay. And what are your contraindications with regard to patients' specific anatomy? Is there any contraindication?
No. Only if they've got very small end plates or the implant is too big for them, and if they have osteopenia or osteoporosis. So a T-score less than -1, we will correct first. So this new drug actually, romosozumab, can do that. We've taken patients from -2 point something down to -1 before with vitamin D and calcium supplements.
Okay.
Discitis is a contraindication.
Discitis, yeah, if any infection, but that would be a contraindication for most surgeries. So
with regards
and extensive bone loss, but I have been bone grafting some of them and using bone cement off-label to fill in bone defects and then put a TDR in. It's like a cemented hip or cemented knee prosthesis, and you're using the cement to fill the cavity, fill the defect.
With regards to Indians' perspective, if you're starting, I can tell you, I do about 1 or 2 in a year, lumbar discs. I used to do much more when ProDisc was there. So that part I don't do as often as him. So the entire day is a celebration when we do it, because I don't keep any other cases and always book a access surgeon. So yeah, L5S1 with experience I've been starting to do on my own, and I've got through without having him around. But L45 definitely he is around. So you have to. So everything about lumbar disc replacement is an elaborate thing, right from the cost of surgery. And it has to be a very well indicated patient, especially when you're starting. He is in a different zone altogether. He is, with experience, he's broken barriers and he's been an outlier. So, discogenic low back pain, one level, have an access surgeon, keep that particular, case, nothing else on that day except that particular case, do it slowly. So I think over a period of time, you will gain confidence.
Yeah, it's the access which is the main barrier, and also the problem. The other problem is the implants. There are not many good implants on the market currently. There's only very few. The US only has one now, FDA approved, which is the ProDisc. The Charité and the Active-L have been withdrawn.
ProDisc, we don't have it right now in India. So
I'm not sure. I'm not sure if you have it in India now.
We don't have it. It's been.
But if you look at your TDR patients, they should all be doing very well. Yeah, they don't have any issue because they don't get any issues.
I did a couple of charities 20 years back. They come once in a while for other reasons. The touchwood is not dislocated.
Yeah, and they don't have the if you did the Charité at 5.1 or at 4.5, the other levels should be fine because the Charité should still be moving.
So great. So we'll wind up for today. It had been a fantastic session, new dimension to the routine talks that we usually have. 20 years back when we spoke of MIS, it used to be about possibility of doing a discectomy. Even treating stenosis was way out. With evolving techniques, we've been able to again break barriers, do fusions, etc. So a day has come wherein we're talking about getting sagittal balance using MIS techniques. That's a big deal, and it's just a matter of time before most of MIS surgeons start doing most of these surgeries with the available techniques or evolving techniques in the future. And Dr. Raymond, he gave a new dimension to this by incorporating, he's actually right, because lumbar lordosis is not constant. We talk of lumbar lordosis in terms of, standing X-ray, but that is not constant. It is food for thought. Maybe, technology would also advance in this particular direction to see to it that, whatever position we take, we are having a particular device that maintains alignment and also provides stability to our deceased patients. So with that, we'll wind up today's session. Thank you, everyone. Thank you, OrthoTV, and thank you, audience, for participating in this session. Thank you.
Thank you. Thank you, everybody.
Thank you, sir.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you, sir. Bye, sir. Bye. Thanks.